All right, chapter 8 is energy balance and body composition. So excess energy is stored as fat. We already covered this. So fat is used for energy between meals. Now, energy balance is when energy in is equal to energy out. And when I say fat changes, it's also weight changes. Okay? So this is where it's a lot of people do calorie counting, so they know to consume less calories than consume less calories than what they burn in order to lose weight, or the other way around. Now, your fat actually gives you a lot of calories. 1 pound of fat is equal to 3,500 kilocalories. It's really good at storing energy. Now, energy in, food intake, hunger. Hunger is a physiological response to nerve signals and chemical messengers, and this happens in your hypothalamus. Influences, presence or absence of nutrients in the bloodstream, the size and composition of your previous meal, eating patterns, the actual climate, whether it's hot or cold, physical activity, hormones, and illness. So these are two words you need to know the difference: satiation and satiety. Satiation is when you stop eating because you're full, and satiety is not to start eating again in between meals because you're satisfied. Okay? So this is the hunger, satiation, and satiety. So this is how the whole system works. Number one, you're going to get hunger. Hunger, you're going to have physiological influences such as an empty stomach. You're going to have these gastric contractions that you feel the pain. There's going to be absence of nutrients in the small intestine. You're going to have your GI hormones also triggered. And then you have endorphins. That's the brain's pleasure chemicals, okay? They're the ones that make you feel happy. These guys are triggered by smell, sight, or taste of foods, and hence even desire for them. So imagine when you're a little bit hungry and you walk into a room or the kitchen and there's food and it smells amazing, you get even more hungry. So these are your endorphins. So number two, you're going to seek food and start meal. This is through sensory influences. You also get influences through sense. So example, thought, sight, smell, sound, and taste of food. Okay? And even sounds. Think of popcorn popping, you know that sound, or when you deep fry something, you know that sound. Number three is you keep eating, and the cognitive influences here are presence of others, such as social stimulation. And this has happened many times. You're not hungry, you go and there's food there, you're like, oh, I'll have some. The perception of hunger, awareness of fullness. There is such a thing as absent-minded eating. So, for example, when you sit in front of the TV and you watch a movie, you're gonna overconsume because you're not thinking, you're not aware of what you're eating or how much in your fullness. Other things that influence is favorite foods, and then foods with special meanings, the time of day, and abundance of available food. Then we get number four, which is satiation. This is the end of the meal. So post-ingestion influences after food enters the digestive tract. So the food in the stomach triggers stretch receptors, and then they send messages up to the hypothalamus to be like, hey, we're done. Okay? This is why slow eaters tend to be thinner because they eat less. Nutrients in small intestine elicit hormones. For example, cholecystokinin. It slows gastric emptying. Then number five is satiety, several hours later. So post-absorptive influences after nutrients enter the blood. Nutrients in the blood signal the brain via nerves and hormones about their availability, use, and storage. As the nutrients dwindle, your satiety diminishes, and then slowly hunger develops, and then you start all over number one. Right, so overriding hunger and satiety, stress eating. We know this. When it comes to stress eating, either you're more hungry or you're just not hungry. Then you get external cues of the day, the time of day, the availability, the sight and taste of food. Then you have environmental influences that we discussed, I believe, is in chapter 1. Larger portions, favorite foods, and abundance. Cognitive influence are perception, memories, and intellect. And then we're going to talk about disordered eating, such as anorexia. All right, so sustaining satiation and satiety. It depends on the nutrient composition. So protein is the most satiating, okay? Low energy density is more satiating than high energy density. In other words, your low energy density, like something that you would get at McDonald's, your low energy density, such as a salad, which has a lot of fiber, is going to be more satiating than a high energy food, such as a hamburger, okay? High energy foods are not as satiating. Also, high fiber foods fill your stomach and give you that full feeling. High fat food actually stimulates appetite. So when you eat something that is high in fat, you're going to be hungry. It's going to stimulate your appetite. So this leads to overconsumption, little satiation during meal. But when fat does enter the intestine, it produces very strong satiety signals. So here's just an example of how you could switch things around. Like, we know peanuts are very high in fat, and popcorn is a pretty good snack. So you want to go into popcorn, obviously try to pop your own popcorn and not use butter. That's the healthiest option. All right, so food intake, your hypothalamus. This is the control center for eating. It also controls temperature, sleep, and fatigue. It integrates messages such from energy intake, expenditure, and storage. Your GI hormones also influence appetite control and energy balance. So total energy a body expend is broken down into 3 categories: basal metabolism, physical activity, and food consumption. Sometimes there's a 4th category involved called adaptation. Now, energy out, basal metabolism. About 2/3 of energy is expended in a day to support basal metabolism. And what is basal metabolism? Well, it's all basic processes of life. So you have two that you've probably heard of. Your basal metabolic rate, or your BMR, and this is the rate at which the body expends energy for specific conditions. And your resting metabolic rate, or your RMR, is similar to the BMR but less stringent criteria for recent food intake and physical activity. So here are some factors that affect your BMR, and yes, there's a lot of them: your age, your height, your growth, your gender, whether you have fever, stresses, environmental temperatures, fasting, starvation. So you could go ahead and read through those. All right, so energy out, physical activity. This is voluntary movement of skeletal muscles. In other words, exercising, moving. It's the most variable component of energy expenditure. Why? Because it just varies per person and what you're doing and how you're doing it and how long you're doing it. So the amount of energy needed depends on muscle mass, body weight, and activity. Now, the frequency, intensity, and duration also influence energy expenditure. Now you have the thermic effect of food. So the acceleration of the GI tract functioning in response to food present. That's what it is. So this acceleration of the GI tract when there's food present releases heat. All right, so approximately 10% of energy intake is used here. High protein foods versus high fat foods. Your thermic effect is going to be greater for high protein foods. Why? Because it's harder to break them down. So it's going to use more energy. Meal consumption time frame. It's greater for meal eaten all at once instead of over a period of time. Obviously, because if you're going to eat one large meal just once a day, it's going to consume more. You're going to have a larger thermic effect than if you do little meals, various little meals throughout the day. Now, adaptive thermogenesis. It adapts to dramatically changing circumstances, such as physical conditioning, extreme cold, overfeeding, starvation, trauma, and other types of stress. The amount expended is extremely variable, and it's not included in energy requirement calculations. So here's a breakdown of energy expenditure. Your basal metabolism is about 50 to 65%, or about 2/3. Physical activity is about 30 to 50%, and the thermic effect of food is about 10% of your total energy expenditure. Estimated energy requirements, you're going to base it on gender. There's a lower BMR for women. Growth, obviously, is a higher BMR for growth, pregnancy, and lactation. Age, the BMR declines with age. Physical activities, so activities are clustered based on intensities, and levels are intensities for each gender. Remember, gender also has an issue. Not an issue, gender also affects your BMR. Now, body composition and body size, so this is the height and weight. All right, defining healthy body weight. So ideal, when it comes to healthy body weight, is not appearance-based, okay? Everybody's a little bit different. I do have some overweight patients that are healthy, okay? Just because you're thin doesn't mean you're healthy. So perceived body image and actual size. That's the other thing. When it comes to your body image, it's very subjective. It's how you look yourself in the mirror. So it's very subjective, and it could lead to damaging behaviors. Like, for example, you have people... like people that are anorexic that look at themselves in the mirror and they are under 50 pounds and they still think that they're overweight. Okay, it's very subjective, and it has very little in common with health. So here are some tips for accepting a healthy body weight you could read through. All right, so defining a healthy body weight, this is where your body mass index comes in, or your BMI. So this is the relative weight for your height, and this is how you're calculated. But there's already a chart you could go ahead and use. So your BMI is, BMI has different types of classification and they're health related. So anything under 18.5 is underweight. Healthy weight is 18.5 to 24.9. Overweight is 25 to 29.9, and obese is anything greater than or equal to 30. Okay, but it's not a measure of body composition. In other words, it doesn't tell you what percentage of your body is fat or lean tissue or anything like that. So here it is. So what you're going to do is you're going to find your height here, and then you're going to find your height here, and it's going to tell you if you fall in underweight, healthy weight, overweight, or obese. I'm 5'2", and I usually fall in between underweight and healthy weight. That's where I usually fall in, and that's how I naturally am. And like I said, some people may fall in this area here in this category, the first two of overweight, which is fine. All right, so BMI and body shape. So the more you increase in BMI, obviously the more fat you're going to have. And in men, you're going to start noticing more of an apple shape, like central obesity. In women, you're going to start seeing more of the hips and thighs, okay? All right, so distribution of body weights in adults. So here you can see most Americans are either overweight or obese. So it's a big chunk of the pie right over here. So we can easily say around over 2/3, yes, are overweights, because this includes extreme obesity, and overweight. Okay, so the vast majority are overweight and or obese. All right, so body fat and the distribution, important information for disease risk. How much of weight is fat and where is the fat located? Those two are very important questions, okay? The ideal amount of body fat depends on a person. So here you have an example of males and females, the ideal, and then the average percentage body fat. So of course we're going to be over. All right, so some people need less body fat, such as athletes. Some need more body fat if you live in a cold climate. Remember, body fat insulates. And also if you're pregnant, you don't want to lose too much fat when you're pregnant, okay? Now, we were talking about fat distribution. So the problem comes when it's central obesity. This is visceral fat. Visceral means organs or viscera. So here you can see on the left is normal, healthy weight person, but on the right is an overweight or probably obese person. And these are your organs here. See how the fat around them actually increased? So this person not only has subcutaneous fat, which is this one, underneath the skin, they also have visceral fat, and this is dangerous. This really does increase your risk for metabolic diseases, okay? So your visceral fat is central obesity, and your subcutaneous fat is usually around the hips and thighs. Now, this is where genetics come in and where your sex comes in. Most men have an apple shape, meaning they get that nice little pop belly. Unfortunately, genetically, that pop belly is considered central obesity and increases your visceral fat. So it greatly increases your chance of getting chronic diseases. For females and normal for men, for females is usually pear-shaped, so they get around the hips and thigh areas, and this is just subcutaneous fat and it's not necessarily associated with chronic diseases. All right, so body fat and its distribution, one way you could check is through waist circumference. So it's an indicator of fat distribution in central obesity. When it comes to waist, women, anything greater than 35 is not good, and for men, anything greater than 40. You could also check the waist to hip ratio, and it's also an indicator of disease risk. There are other techniques for body compositions with more precise measurements. So here are some of them. So you could here are some different methods to assess body fat. Your bioelectrical impedance, I've done that. It actually sends these little electrical charges through your body. You don't feel them. And not only does it give you the percentage body fat, but it also gives you your water content. So it could tell you whether you're hydrated or dehydrated. DEXA, the ones that they use for bone scans, can also be used for this, as we saw, I believe it's in the first video that you guys saw, or the first film about obesity for your discussion. All right, so health risks associated with body weight and body fat. So body weight and fat distribution correlate with disease risk and life expectancies. But remember, correlations are not causations, okay? Risks associated with being underweight, unable to preserve lean tissue when fighting against wasting diseases, menstrual irregularities and infertility, and osteoporosis and bone fractures. So your BMI and mortality, as in dying, okay? If you have a very low BMI, the risk of mortality is high. But once you start going to normal weight, you're okay. But the minute you hit obese, it skyrockets again. Okay? So the risk of dying is gonna increase as your BMI rises. So risks associated with being overweight, obesity is already a designated disease. All the other risks associated with being overweight: cardiovascular disease, type 2 diabetes, chronic inflammation, metabolic syndrome, and cancer. For CVD or cardiovascular disease, you get elevated blood cholesterol and hypertension, and this you also see the central obesity. For type 2 diabetes, you see the central obesity, and you see weight gains and body weight increases. For cancer, the relationship is not fully understood yet. For inflammation and metabolic syndrome, you're going to get chronic inflammation, and this is going to lead to chronic diseases. So your metabolic syndrome actually changes your metabolism. You start getting insulin resistance, you get low HDL, high triglycerides, and high blood pressure. Again, cancer, the relationship is not fully understood. So fit and fat versus sedentary and slim. Right? So like I said, there are people that are slightly overweight that are fit, they exercise and they eat healthy. That's the way they are. And then there's some people that are sedentary. They don't move, but they're skinny, just naturally skinny. So that person is fat on the inside, skinny on the outside. So it doesn't necessarily mean they're healthy. All right, so let's cover a little bit of eating disorders. So you have 3 types of eating disorders: anorexia nervosa, bulimia nervosa, and binge eating disorders. So the prevalence of various eating disorders, I'm so sorry. Let's break down the prevalence of various eating disorders. Anorexia, about 0.9% of women suffer from this, 0.3% of men. Bulimia, you get 1.5% of women, 0.5% of men. And binge eating, you get 3.5% of women and 2% of men. So that one is the most common one. Causes: multiple factors. Social, cultural. Yes, our society is obsessed with the way you look and obsessed with, I think, too skinny people. Then you have psychological, and also it could be just a neurochemical. It could be an imbalance of your neurotransmitters. Athletes and eating disorders. Interestingly, athletes are more likely to develop eating disorders. Think of certain sports that you're required to be thin, such as gymnastics, or that you're required to be a certain weight depending on the category. Think of boxing, okay, featherweight, etc. All right, so let's talk about the female athlete triad. This is considered disordered eating, unsuitable weight standards, okay? So a lot of times this does happen to young girls that are in sports, particularly sports that require certain physique, like I said, like gymnastics, okay? Now the problem is that body composition differences, in other words, it's different in every person, okay? Risk factor, so this is going to increase the risk factor for eating disorder in athletes. Females that do have eating disorders can suffer, and most do suffer, from amenorrhea. Amenorrhea is the absence of menstruation. When you don't menstruate, you have low blood estrogen, you're infertile, and you start losing bone minerals. Okay, so you start getting bone mineral loss. In other words, osteoporosis, even if you're young. So amenorrhea among the general female population is only 2 to 5%. Among female athletes is 66%. And this is very, very harmful to a girl that is still developing. Okay, so like I said, the bone mineral loss is going to lead to osteoporosis, and it's going to lead to stress fractures. Stress fractures are not just that you fall and break a leg because of the impact. It's really odd fractures. You could be running and your hip fractures or your femur fractures. And it's because of the osteoporosis making your bones weak. So this is what the female athlete triad is. You have a eating disorder right up in here. Sorry, let me go back. Eating disorder, so restrictive dieting. So you get inadequate energy intake and nutrient intake, over-exercising, weight loss, and lack of body fat. This is going to lead to amenorrhea, which is diminished hormones, and it's going to lead to osteoporosis because of the loss of calcium from bones. But at the same time, the eating disorder, you're probably not getting sufficient nutrients, which also increases the loss of calcium from bones and affects your bones in other ways. All right, so muscle dysmorphia. This is mostly in men. So again, this is a distorted body image. It's very similar to other distorted body images. It's men that go to the gym and they don't think they're big enough. Their muscles are not big enough. So they start having a high protein intake to increase muscle and weight. They have to be very careful because a lot of them do damage their kidneys. Food deprivation and dehydration practices impairs physical performance by reducing muscle strength, a decrease in anaerobic power, and reducing endurance capacity. So here's some tips for combating eating disorders you can go ahead and look through. Now let's talk about each one specifically. First one, anorexia nervosa. Again, it's a distorted body image. Is central to diagnosis is that it's subjective. You don't think you're thin enough regardless how thin you are. And it cannot be self-diagnosed. You're going to have malnutrition, and this impacts brain function, judgment, causes lethargy, confusion, and delirium. Levels of denial are very high among anorexics. They don't think they have a problem. Another thing about anorexia is the need for self-control. They need self-control. So they crave it. So there's a thing. They're starving, but they're like, you know what? I'm in control of my body and I'm not going to eat. Okay? So you get this type of malnutrition called protein energy malnutrition, or PEM or PEM. It's similar to marasmus. The impact on the body: growth ceases and normal development falters, changes in heart size and strength. A lot of times your heart size actually decreases and becomes weak. And there's a bunch of other bodily consequences too. You're starving to yourself pretty much. Treatment is a multidisciplinary approach. It's not just a psychiatrist, a psychologist. You need a nutritionist, a general doctor, a life coach, an exercise coach. You need to address food and weight issues and also relationship issues. Some relationships are psychologically toxic and it could lead to eating disorders. After recovery, unfortunately, energy intakes and eating behaviors may not return to normal. There is a high mortality rate among psychiatric disorders. All right, bulimia nervosa is distinct and more prevalent than anorexia nervosa. The true incidence is difficult to establish because it's very secretive in nature. You may actually have friends that are bulimic and you don't know it. It's very, very secretive in nature, and it's not as physically apparent as anorexia. Common background characteristics of bulimics is white, female, single, and well-educated. Again, the Western culture's obsession with body image. All right, so with bulimia nervosa, you get a binge purge cycle. And different to anorexia, that is control, self-control, the binge purge cycle is lack of control. So you consume food for emotional comfort, you cannot stop eating it, and you do it in secret. So this is binge eating. I'm not talking about 1 or 2 donuts. I'm talking about the entire box of 12 donuts, okay? But then you feel guilty, you feel disgusted with yourself, so you purge. All right, so you purge. You could just stick your finger down your throat and throw it up. Or you could use strong laxatives, which are called cathartic, or emetic, which are drugs that causes vomiting. And then this also gives you feelings of shame and guilt. So this is the vicious cycle of restrictive dieting and binge eating. So you get negative self-perceptions. You do restrictive dieting. You fail, so you binge eat because of the emotions. Then you feel guilty and disgusted with yourself, and you purge, and then again, negative self-perception. So this is the vicious cycle that happens. All right, bulimia nervosa, so physical consequences of this. Subclinical malnutrition, you're going to get a compromised immune system. Fluid and mineral imbalances may lead to abnormal heart rhythms and kidney injury. UTIs, which are urinary tract infections, may lead to kidney failure. Physiological effects, you're going to get tooth erosion. Why? Because if you're throwing up, you're going to get all that acid coming out, okay? Red eyes, because you may pop a vessel. If you guys have ever thrown up, it's happened to some of us. And calloused hands. Others include infection of the pharynx, esophagus, and salivary glands because of the continuous vomiting and irritation of that area. It's also associated with clinical depression. So clinical depression and substance abuse rates are very high amongst bulimics. Treatment, you need to discontinue purging and the restrictive diet habits. Learn to eat 3 meals a day plus snacks. You do need a treatment team, so it is multidisciplinary, and the length of recovery does vary per person. The overlap between anorexia nervosa and bulimia nervosa is all body image, and it's all subjective. So here are some diet strategies for combating bulimia nervosa. Alright, so binge eating disorder is periodic binging, but typically there's no purging. You just binge eat. Contrast with bulimia nervosa, you consume less during binging and there is no purging. Compared with bulimia nervosa, you still get the feelings of guilt, disgust, and non-control. The difference between obese binge eaters and obese people who do not binge is self-loathing and disgust. So people that binge eat, a lot of times they do it because of this emotion that they have. They hate themselves and they're disgusted with themselves. But obese people that do not binge usually don't have these feelings, okay? This behavioral disorder is very responsive to treatment because it is very psychological. All right, so eating disorders in society. Society plays a role in eating disorders. It's only known in developed nations, more prevalent as wealth increases. Why? Because food becomes plentiful, and we don't know what it is to really starve ourselves, not to have food. We take things for granted. It also has to do with body dissatisfaction, so that's huge because of the society and also our relationships. Characteristics of disorder eating, again, all has to do with body image and body dissatisfaction. It's very subjective. All right, and that is it.